it's my pleasure to introduce my anchor person that is going to give us the objectives of the session. So we are going to encourage you to come up with questions. We will have a short time after each presentation, so prepare them, have them ready, and Gianluca, let's kick off.
Yeah. So just one short slide to show the aim of this session. So in particular, to learn how the new generation of QFR technology allow to measure FFR. FFR just not as a single distal value, but also as a FFR pullback in around 30 seconds. The second aim is to understand how this technology may help a physician in the assessment of the microcirculatory component, in particular how we can perform the diagnosis of microvascular dysfunction and how we can improve the management of the patient. Finally, we want to learn how the application of QFR technology may improve patient outcome.
Thank you, Gianluca. And we are going to start with the first presentation by a dear colleague, Salvatore Brugaletta, who is going to present to learn how the newest QFR 3.0 technology enables coronary vessel analysis in 30 seconds. I cannot believe that.
Yeah, I will not do the presentation in 30 seconds, so that's for sure. But I will try to do my best. So thanks, Hector, for introducing me. I would like also to thank Medis and GE, because I feel proud that so this is the first time that I introduced to you the QFR 3.0. So what is different with the QFR 3.0? So you know that the QFR is a software to evaluate the physiology, so the FFR, but by angio, so without any guide wire, without any microcatheter, just by angio. So I guess that we all know about the QFR 2.2, so which was the previous version. And the difference between the previous software and this new one, so actually summarized here in this table. Which are the most interesting to me? Actually, so the first three, so we came down from 7 steps, so which was the previous version. If you have some experience about that, you know that there were different steps and you have to confirm each step, so to go for the next one. In this new version, so we have 3 steps. So if we have to stay in 30 seconds, I will say that each step so takes around 10 seconds. Second feature, which to me is also interesting, is that with the previous version, you should have the software installed in your hospital, in your laptop, in your hardware there. But with the new software, you may have in a sort of browser, so you don't need to software installed over there, but you may have on the cloud, and then you may export to your cases. And of course, so the analysis has been cut down, so they say by twice, so from 60 seconds to 30 seconds. But to me, you will see, so the most important thing is that it is much more easier. So how it works? So as usual, so we have in the Cath Lab, so we have our patient over there, so we acquire some angio. And of course, so we are interventional cardiology, so we are not worried how the angio is going over, but we know that so there are some packs, so the images are stored, and then so the Medis is taking actually this image coming directly from the X-ray machine, so to the software. So we don't have to be worried, to go from one copy and paste, etc. So is everything automatically done. And then so what is the user face? So this is the normal user face for this 3.0. So we just need, username and password. And I will go through so the different steps. So we have all the different patients that are in our Cath Lab. And then so we selected the one that we are interested to do the QFR. So usually, so what I do in my practice is, for example, 3-vessel disease, and I will show later on an example. So the software is showing here on the top, so all the angio that are available. Then you select one, and I must say that when you select, for example, the LED, automatically recognize the vessel in the sense that the other angio that you have on the right is always the angio that are compatible with the first one. So it's very easy, to take. In this case, so that is an example of a LED. You see that we need 2 different angles, at least 30 degrees. And then so we just go for the next, so nothing more than that. And the software automatically, so this is something new, newer as compared to the previous version, is giving us already the PET lines, the contours, so we just don't need to make points from here to there, and then so the software is making this correction automatically. Everything is done, so we just need to check that everything is fine. We just need to make some minor correction. So once we are there, so we just go to next, so nothing more than that. And then so we have these two different projections with the QFR. So of course these are QFR based on the two dimensions, so then the two different projectors should be mixed together. So in this case we have two lesions A and B, so QFR is 0.62. So we have also some calculation of the residual QFR, so which will be after the treatment, and then we may play here to show from where to implant the stent. This will be the first projection, this will be the second projection, and finally, so we have the two projections together with the 3D model that we are all familiar with. And we know, so not only, the QFR on the bottom here, but also the morphology, the diameters, the length of the stent which we may implant, we may simulate, so from where to implant the stent in order to increase this QFR up to the value that we want to achieve. So everything is, of course, with a report, so we may print it out, and that's it. So, but there is another feature which is interesting to me, which is the complete integration with the QFR, with the Alaya machine. You see that we are in the Cath Lab, the patient is over there, so we acquired the 2 angio. We don't need actually to remove our gloves to go out of the room and to make the calculation, but everything can be done inside the room, so in the table by using the mouse. And then, so what is interesting is also that we may rotate the X-ray machine, and automatically, so with the rotation of the X-ray, so we see that the image is rotating as well. That is, to me, very important when we have to find out which is the correct or the most appropriate orientation, so to see, for example, where the stenosis is located, so if we want to localize perfectly well, so from where to implant the stent. So that is an additional feature which to me so looks very interesting. So let me show you, a case. I guess that, so we are interventional cardiologists, so we are very interested to make cases, and we do a case like this one that I present to you. So he's a male of 76 years old. So these are the cardiovascular risk factors. So the patient had a large history, so started in 2019 with a PCI of LAD. He was okay until 2024, so it was actually 2 months ago. So he came back for stable angina. So in this case, the GP was quite good because they started with the optimal medical treatment, but despite that, so the patient was still symptomatic, and that was the reason why the patient came to us. So we did the angio. So you see that there is the LAD. Here we see the old stent, so everything so looks very calcified, but here we see the stent. And we see some restenosis, so it's moderate, I would say 50% restenosis in the middle of the stent, that we don't know if the stent is underexpanded, if it could be physiologically significant or not. Then we see the circumflex. Circumflex is very small, but we see that there is some diffuse disease here. So we have some stenosis, which looks, at least to my eye, so significant, I would say 80 to 90%. And eventually, so we have the right coronary artery with this long diffuse disease. Okay, I would say 70, 80%. So what to do with this patient? So either we can take it out from our lab, and then we may discuss with the surgeon, so which will be the good solution. Either we may treat the one lesion, or so my solution will be to do physiology. So either with the FFR, but then so we have to open the guide wire, or with the QFR. So we made it, and these are actually the results. So we made the QFR, so as I show you, everything was easy. So just step by step. And then, so this was the result from the LAD. So the restenosis was not statistically, also not significant, it was 0.87. So then we went to the circumflex again. So selection of the two images, so the white lines is here, and then so the QFR is 0.96, so it was again negative. And finally, so this was the right coronary artery. So right coronary artery was positive, so 0.69. So here you may play with the distal marker that you may see here, so to understand from where to where, so to put the stent. So here, for example, with a long stent, so it was a QFR of 0.92, and then so we decided to implant a stent. It was a 3.538 millimeters, so this was the final result. The patient, so 2 months has passed, so he's still okay, so now he doesn't have an angina. So these are my take-home messages. As you have seen, so QFR is faster, so easier to use. To me, so it's important both characteristics, so not only mean the time that you consume, but also the fact that you just have to click on the next, so you don't have to make any much more drawing. So it's interesting also the integration with Alaya, especially the fact that you may rotate the X-ray machine, and then you see also the QFR which is rotating, so that it helps you to select the correct projection for making your angioplasty. And of course, so QFR, so it's always, welcome when we have to take decision, especially in patients with 3-vessel disease. And many times, I guess that we all face the problem that patients are coming to us without any stress test, and we don't know so what to do. Thank you very much.
Thank you, Salvatore. Great presentation. So I open the floor for questions from the audience. We have a mic here in the middle. So please stand up and ask your questions. While somebody dares to come up, Salvatore. So 3 clicks, right? 3 steps. So 3 clicks. Next, next, next. And you are pretty much with the results in front of you. And what really makes a difference for me in your presentations is the integration of the system into the GE ALIA equipment. That makes it so much easier. You don't have to have a laptop next to you. You don't have to transfer the images. It's all integrated. And then you play with the joystick. So is that the future? So you think this QFR 3.0 should go in every system to make life easier and optimize the diagnostic evaluation of the patients?
Yeah, I guess that we are talking about the Cath Lab of the future, no? So, and the Cath Lab of the future should be something integrated. So that means that so you don't have to struggle with taking another machine, another computer inside the room, or even the cables. No, I'm thinking about IVUS OCT imaging techniques should be Bluetooth. No, that is the future. So I guess that any kind of integration so is very welcome because it helps you to make the job. So you stay in the Cath Lab. Sometimes you have to go out. So in another room, the patient is left alone. Then you have to take the measurement. That you come in again. And that is consuming time, no? And we know that our Cath Labs are always very busy. And what you need so is to go to take a decision very fast, so to go from one patient to another.
No, very important. So if anyone has a question, we have still 1 minute or 2.
Yeah.
Yeah.
Correlation between QFR and FFR, any compared to head-to-head study, sensitivity and specificity of QFR?
Yeah, I can tell you, I didn't show, but in this patient I did as well FFR, and everything was the same.
Yeah, no, and in general, it's going back 10 years ago. So 10 years ago, the first publications in JAK interventions comparing this tool against invasive FFR. Accuracies are above 0.9 and sensitivity and specificities in most of the studies. There is even a meta-analysis by Colette where he pulled all these studies because there are many, many, many. So on average, the sensitivity and specificity are also in the range of 90%.
Yeah,
so
the most important thing is that you take the correct projection because, of course, so if you have some foreshortening, so you are reducing the viability of a QFR. So take a good projection, make a good injection. So make sure that you have a frame rate of 15 at least, and that's it.
And sometimes it's more accurate than FFR. So maybe FFR is not a good comparison. I will show you a case of a tortuous LAD where I think for FFR you would have had a false positive because it straightens the vessel too much.
We have another quick question.
This QFR is only compatible with GE machines?
no,
I'll show you.
with all.
Okay. Great. If you prefer, you can use also the app for a question. So we have a similar question, so comparison with FFR, so we reply to the question. But please, if you don't want to use the microphone, you can use the app for the question. Okay, we can move to the next speaker. So it's a pleasure to introduce Adrian Jeronimo. We move from the epicardial assessment to the microcirculation assessment. So we will see how QFR IMR can be helpful for the assessment of coronary microcirculation.
Thank you very much for the invitation to this session, to do this presentation. Also, on behalf of my colleague and mentor, Javier Escanet, who is flying to Madrid now to perform the live cases tomorrow. I have no disclosures. And to understand how the microcirculation works, the first thing is to understand the most important difference between the epicardial vessels and the microcirculation. The main function of epicardial vessels is conductance mainly, whereas the main function of the microcirculation is the regulation of the blood supply to the myocardium, and we test its dynamicity by CFR and its resistance, which is actually the inverse of flow, by IMR, HMR, or MRR, among other indexes. So why does high IMR and high resistances come from? Well, they may come from several causes, but the most important ones, I think, are summarized here. They can come from structural remodeling of the microcirculation, inward hypertrophic arterial remodeling, arterial rarefaction, etc. It may come from extravascular compression. It may come from embolic intraluminal obstruction that we all cause during PCI or, of course, during acute coronary syndromes. Or they may come also from arterial constriction resistant to adenosine, which is a much more unknown entity, and that may also be related to Rocky-Nice function. Of course, we have seen that we are able to measure and to infer without a wire inside the coronary artery both pressure and flow, but I assume we agree that it's desirable to be able to measure resistances, and that's why that's what angio-IMR comes to answer. So we know IMR is basically depends on intracoronary pressure, the distal pressure that we call, and the mean transient time, which is a surrogate of flow. So we can infer intracoronary pressure by knowing our arterial pressure and also QFR. And we can also infer mean transient time by QCA, knowing the length of the vessel we are dealing with, and also the frame count velocity, which is basically the velocity at which the contrast media flows to fill the vessel. And then we can, or we may or may not apply a correction factor. So basically with this simplified formula, we will be able to infer angio-IMR or IMR without a wire. This is an example. If we are dealing with this vessel and we know that arterial pressure is 93 millimeters of mercury, for example, simply by our catheter, we know the distance we are assessing in this vessel by QCA is 58 millimeters, and we, by frame counting, know that the velocity of the flow is 22 centimeters per second, and QFR is 0.96. After applying the formula, we can get an angio-IMR of 21 units. And several approaches to angio-IMR have been developed by several groups. First of all, a group by Scarsini and De Maria, using QFR and hyperemic angiograms, have come out with the IMR angio index. Also, Tebaldi and Campo using also Young's formula to correct the collateral circulation effect. Also, our group from Hospital Clínico with angio-IMR using resting angiograms and the correction factor to adjust the pressure drop during hyperemia, and also other indexes from Chinese colleagues using KFFR in this time, resting angiograms and measuring diastolic resistance. So what are the main opportunities or the main utilities we can get for angio-IMR? There are several, and I'm going to try to summarize some of the most important ones. First of all, in the field of INOCA, of course, it may identify patients with elevated resistances in the microcirculation, and there is some evidence on this regard. In a prospective cohort of more than 100 patients with suspected INOCA and normal coronary arteries, our group performed a correlation between invasive thermodilution-based IMR and angio-IMR, showing a pretty good correlation, and also with an area under the curve at 0.87, which relates to a very high negative predictive value. That means that basically we can rule out the presence of microvascular dysfunction if we have an angio-IMR under 25. Other approaches to validate the use of angio-based microvascular resistance indexes in patients with normal coronary arteries has been the FLASH IMR study that compared IMR, invasive IMR with Ka-IMR, also with a good correlation and also good sensitivity and specificity. To continue, another use of angio-IMR may be the use to complement QFR, because we know that there are some patients that have discordant QFR and FFR values, and here we know that the microcirculation may have something to say about. So this is an example. We have a vessel with an intermediate stenosis in the left circumflex that if we measure an FFR is 0.82, and we have also the determination of the IMR, which is high, 40 units. But if we perform QFR in this vessel, we may observe that it's 0.69, so it's positive, and we would assume it's a false positive in this case. So this has been tested also in several studies so far, and FFR and QFR, as I said before, may be sometimes discordant, as the colleague was commenting in his question before. Probably because the microcirculation has something to do. So it may be very useful to know angio-IMR, especially to make sure that the value we are getting with QFR is true, is not a false positive, especially when FFR is normal. So this is a cohort of patients with suspected with coronary artery disease, in which we performed FFR and QFR. The red dots correspond to the patients that had discordant values of QFR and FFR, and as you can see, most of these red dots correspond to patients that have positive QFR and also high values of angio-IMR. So if we calculated the predictive positive value of QFR in this cohort of patients, it was 80%. But when we took out of the equation, we erased the patients with discordant QFR and FFR values, the red dots, the positive predicted value went up to 91%. Then another possible application of angio-IMR techniques is the culprit stenosis in STEMI and the identification of coronary microvascular dysfunction in this subset of patients. As we all know, microvascular obstruction in STEMI detected by MRI is associated with bad outcomes, and there have been several approaches to the determination and to the validation of angio-IMR to predict this phenomenon and to predict IMR in this subset of patients, one by the group of Scarsini and also one by our group, with similar and parallel results, concluding that angio-IMR is able to predict microvascular obstruction in MRI. And also, if we take a look at the prognosis of patients with high values of angio-IMR in the context of STEMI, we see that both in a binomial fashion and in a continuous fashion, high values of angio-IMR are associated with bad outcomes. And finally, the last application of angio-IMR techniques, one of the most important ones, may come from the evaluation of the microcirculation in patients that receive allografts, that receive transplants, because we know that the microvascular dysfunction is highly associated with bad outcomes after the transplant, from several years ago, we know that values of IMR in these patients more than 20 relate to bad outcomes in terms of needs of retransplantation and also death. And if we take a look also at more contemporary cohorts, we see that having a reduced microvascular dysfunction is associated with as worse outcomes as to have obstructive coronary artery disease in these patients. And this is just the final slide, just to, if you want to go more in deep into functional angiography techniques, you can take a look at this QR code to read this last year's intervention state of the art that will help you go with it. Thank you very much.
Great. Thank you, Adrian. Thank you so much for your presentation. I have some questions from the audience for you. In particular, I believe the audience appreciated your slide when you have the integration of angio-FFR, angio-AMR in comparison with FFR. The question is, if you have a borderline value of FFR, so 82, 83, and so your suggestion is to reassess the vessel with QFR and angio-AMR, trying to understand if is a patient with false positive. So if you can explain better this important topic and how you can imagine in the future the integration of epicardial and microvascular assessment.
Thank you. It's a fantastic question. I think we are all going together to the Cath Labs of the future, as Salvatore was suggesting before. And I think the future is to get as much information as we can from an invasive procedure as an invasive coronary angiography that we are performing in our patients. So once we have integrated in our Cath Labs and in our daily practice QFR, I think it's most important to do it together in a parallel way with angio-AMR in order to understand what the microcirculation has to do with this. Because otherwise, especially in patients with positive values of QFR, if we are not sure about the status of the microcirculation, we may be probably treating lesions that we might be able to defer and causing an over-treatment in these patients. So I think the future is to integrate both tools in daily practice.
So if I can do a brief comment, this is an important application in particular for the stratification of non-culprit lesion of my patient, because we will know that if we perform wire-based assessment, in particular during the index procedure in the non-culprit lesion, we may have some value altered by the microvascular dysfunction. So QFR combined with the angio-AMR become the perfect tool to stratify non-culprit lesion, and you can do also offline. So you are focused in the treatment of the MI patient, you treat the culprit lesion, you stabilize the patient, and the day after you can integrate the analysis with angio-FFR, angio-AMR, and you can decide if the patient come back to the Cath Lab to treat the non-culprit lesion or go home with a very good prognosis. So thank you so much.
Thank you very much.
Thank you. So we are moving on, and now a talk that is going to be presented by Dr. Victor Tadros is QFR and Freesolve by Biotronik. It's been launched here, so we'll learn more from Victor.
So thank you for the invitation, this wonderful symposium, and give me the opportunity to share with you some useful tools from Medis to plan the procedures, and let me introduce you the new performance of the new resorbable magnesium scaffold from Biotronik. Here's my disclosure. So let me start with some daily practice that we all met in the Cath Lab with a clinical case. He's a 45-year-old male, new onset chest pain during exercise. His risk factor is family history of CADs, probably pre-test probability of CAD is 22%, so he had an angio-CT scan. The Q-angio-CT analysis of this patient showed low-density lesion of the proximal LAD And when we go deeper with this analysis, we can notice that the tissue plaque is made of necrotic core, confluent necrotic core massively, and fibrofatty tissue, suggesting a vulnerable plaque in this proximal LAD. Here's the angio that confirms that. And as my colleague mentioned earlier, QFR 3.0 is a very useful tool for functional assessment, and we can retrieve many data from that. This QFR shows two lesions, one in the proximal and one in the mid-LAD. The physiological assessment with the differential analysis shows that lesion A was the most important lesion with the dQFR over DS with a high pressure gradient and a focal lesion, and with the comparative mode with the lesion B and the mid-LAD that showed that it was not relevant to treat it with a delta QFR of 0. So from this functional assessment, we can assume that we have to treat the proximal LAD. Now, switching to the morphological aspect of the QFR 3.0, this is a very useful and accurate tool in 3 clicks steps to help and have accurate dimension of the proximal and the distal reference diameter and the length of the lesion to choose right the endoprosthesis you want to treat the patient with. In this case, we did an OCT analysis that showed a massive focal lesion with a massive necrotic core circumferential. Now, a second clinical case with a 55-year-old male, recent angina, current smoker. He had also a CT scan that we analyzed with the Medis application Q-angio-CT analysis, and that showed this time on the left circumflex lesion with hypodensity and eccentric remodeling. When we deep analyzed the lesion, we also saw a massive necrotic core with predominant fibrofatty tissue. So again, a vulnerable lesion. Here's the angio again. And when we analyze the QFR 3.0 analysis, we have a 0.76 functional assessment. It's an only lesion, single lesion, sorry. And with the morphological assessment, we have a reference diameter of almost 3 and a lesion length of 28 millimeter long. In this case, we did the QI-VUS assessment with the Medis system that showed this lesion, and virtual histology showed a plaque burden of 77%, MLA of 2.1 square millimeter, thin cap fibroateroma type, lumen diameter reference of 3, and lesion length of 20 millimeter. So why do we interest in bioresorbable scaffold? Because stents were a revolution in the past, but they're still responsible for stent-related events, and with an increase over the years. And for the last 30 years, we've been interested in the bioresorbable scaffold and leave less behind strategy. The idea is to have a temporary scaffold that provide mechanical support during vessel healing, to preserve distal bypass grafting sites in case of disease progression and prevent long-term stent-related events. But still, the technology is hard to get there and was not as mature as the stents was. The most evaluated is the L-polylactic acid, on top of the list, the Absorb Abbott stent scaffold, sorry. And in this recent meta-analysis, it was not good enough with not safe enough with the more stent thrombosis and target lesion failure. But another technology has emerged with the resorbable magnesium scaffold technology with the Magmaris the DREAMS-2G, that showed a safety profile that was promising with a very low stent thrombosis rate and good TLF compared with the standard DES stent. But what's the expectation for the new generation BMS? RMS. We need increased support to provide late lumen loss. We need reduced shots to provide stent thrombosis. And this Biomag or free-solve stent, this was studied in the Biomag 1 study, and he had improved mechanical support compared to Magmaris, now approaching stainless steel capacity. The first in-human study to evaluate the performance of this scaffold was studied in Biomag 1 and was concluded last year with a follow-up of 6 months in late lumen loss with the primary endpoint with the intracoronary imaging and vasomotion reactivity. And as you can see, the mean in scaffold late lumen loss was 38% better in the Biomag 1 in absolute number compared to Biosolve, the Magmaris study. So this is very promising. And there were only 3 events, so 2.6% of target lesion failure clinically driven by clinically driven target lesion revascularization. The imaging showed that after 12 months, the scaffold was completely resorbed in 99% of the patients. The sub-studies imaging showed that the underlying plaque characteristic had no significant impact of late lumen loss in the free-solve, suggesting a better device performance. And although it was a low number of patients, vasomotion was restored at 12 months as well. And this is probably the most important data showed from Professor Garcia here, that there was a temporary changes in the plaque characteristic by imaging with a decrease in lipid area and increase in fibrous tissue, and also an increase in thickening of the fibrous cap that suggests that may have a role of stabilizing the vulnerable plaque and prevent plaque rupture. Biomag 2 is now just started, and it's a randomized controlled trial evaluating the free-solve against Xience family with a primary endpoint of target lesion failure at 12 months. So back to our clinical case, patient 1 was treated with the free-solve 3 by 18 millimeters. And as you can see, OCT control show good apposition of the stent with the good visible struts of the scaffold. And patient 2 received the free-solve 3 30 millimeters with a good control. And IVUS imaging showed good apposition with no underexpression of the stent. So I couldn't leave this session without talking about the PREVENT trial that was presented at the AHA 1 month ago. And they were interested in the non-culprit, functionally non-significant but vulnerable lesion defined as 2 criteria among MLA below 4 square millimeters, plaque burden over 70%, thin cap fibroateroma assessed by IVUS or OCT, or lipid-rich plaque by NIRS spectroscopy. And they showed that they were randomized between optimized treatment only or optimized treatment plus preventive angioplasty. And the angioplasty group had better outcomes with the primary outcomes that came positive, with a less primary outcome with the angioplasty group. And as you can see, 1/3 of the patient had BVS implants. So let me conclude that QFR becomes an easy and quick tool for non-invasive physiology, and it can give lesion-based and vessel-based analysis, and it also helps planning the angioplasty with the morphology features of the 3D reconstruction of the vessel. The new generation resorbable magnesium scaffold FreeSolve shows better mechanical properties and longer scaffolding period over time, but still resorption at 12 months. This is promising observation that vasomotion is restored, and it may have a role in stabilizing the plaque. And thus, we have to know who would benefit the most of this technology, targeting young population or bypass sites, or targeting vulnerable lesion like lipid-rich Thincap fibroateroma. Maybe we can think about the Prevent Resorbable study. Thank you for your attention.
Okay. Thank you, Victor. We don't have time for any question because we have to introduce the last speaker. So thank you for your wonderful presentation. So it's a pleasure to introduce the last speaker, so Joanna Wykrzykowska, that will illustrate how in a busy Cath Lab QFR technology may improve the workflow.
So thanks for having me as a dessert. So indeed, we have a busy Cath Lab, tertiary Cath Lab in Groningen, and I'm really impressed with QFR 3.0. So we don't work with GE, but with Siemens, so we don't have the joysticks, but you can integrate it as well. So on the same computer that you use usually for your IVUS OCT or your Coroventus FFR, you can basically put the browser on. And then you actually see the images also on the big screen in the Cath Lab. So you can see here that on the picture. And you can usually communicate with your analyst as well. And most of this is really automatic. So you only have to give them advice about correcting the contours. So you can follow the analysis live on screen. All steps indeed happen automatically. It really saves a lot of time in multi-vessel case evaluation. You don't have to take out your wire, and it is really 30 seconds. So this is one of the cases that we did, an RCA case. The angiogram is loaded into the software directly from your angio system, as Salvatore also said in real life. And then essentially you can pick out which vessel you're interested in analyzing. So it will indicate, once you indicated the vessel, all the steps of frame selection, diastolic phase, proximal and distal points happen automatically through inbuilt IE software. I was used to doing a lot of cases with QFR 2.0, which was also excellent. So I was a little bit nervous of losing control of, making sure that all the points were correctly made. But it does a really good job. And actually, contour correction, if you made a good picture without foreshortening, is not really much needed. So this is one of those examples of the QFR. You can see a positive lesion, and we know that this lesion has to be treated. Again, you also have information about what will be the QFR if I treat this segment with a stent. You don't forget that with QFR, not only do you have the physiology, but you also have your diameters, proximal and distal, of the vessels. So your stent sizing will get better automatically, and also you can determine the length of the stent using this. So this is the 3D reconstruction, and the way that I also know that this is doing a good job, look at the line of correspondence. It's perfect, right? It's better than what my technician used to get with all the steps that they did themselves with 2.0, I think. So a couple of cases. Patient 1 with also 3-vessel disease. A 60-year-old man with history of PCI in both the RCA and the CX several years ago, now crescendo angina. and normal kidney function, normal ejection fraction, and what we calculated a syntax score of 17. So you can see that based on the syntax score 2020, he has equipoise for an actually fairly low event rate with both CABG and PCI. But does he really need a CABG? That's the question in the Cath Lab. And indeed, instead of going to the surgeon, we again did first LAD analysis. And you can see that this LAD vessel is very tortuous. So I think QFR here is positive, of course, but there are some cases where when you have such tortuous vessel, your FFR will be falsely positive and the QFR will show that the actual vessel is okay. So it performs well even in tortuous anatomy. We then proceeded to perform QFR of the other two vessels, and you can see that the circumflex was 0.9 and the QFR of the RCA was only 0.81. So we treated the LAD ad hoc at the table, and he was done. So the functional syntax score was much, much lower than the syntax score based on the initial pictures. And now the second patient is 57 years old, but has type 2 diabetes, CVA or stroke in 2021, smoker, average ejection fraction or mildly depressed ejection fraction, and severely depressed on MRI, and an anatomic syntax score of 20. So, but given all the features, clinical features, he has much higher mortality with both procedures and slightly higher with PCI than with CABG. So here we also proceeded to use angio for assessment, and you can see that the angio of the LAD was 0.74. Again, nice correspondence line, so you know you were doing a good job. Also, unfortunately for him, the RCA and the circumflex were positive at 0.64 and 0.79. And so he actually had the same anatomic and functional syntax score, and he was referred for CABG through the heart team. So you can see that it can make your life easy. In the past, I used to check with FFR if it's correct, and indeed, it was so accurate that I don't do it anymore, and I believe in this more than an FFR.
Thank you, thank you. So, thank you, Joanna. And it's time for you take your message.
I think I'll close from here because otherwise it would take me a full minute getting there. I'm very slow walking. So things to remember, take home message, 3.0 is the key number, 3.0 the new version of QFR, 3 clicks away for completing a 30-second QFR analysis according to Salvatore Brugaletta. And integration with GE alias system is the way to go. And thanks to also Biotronik for showing us this free-solve technology. And the future is here. So all these products are CE mark, readily available. Go to the booth if you have remaining questions because we have no more time. We'd like to thank you all for your participation and the speakers, of course.